Very good morning, students. Today we have got a very interesting topic. Actually, this is continuation of previous one. Previously we have discussed topic of fever or pyrexia that you are all well aware of. That means you have studied, gone through that, though it was exhaustive, almost 1 hour topic. I feel some points might be at least useful for you, like definition of fever. So all these things are important. Most of the fevers, they do subside within a span of 1 or 2 weeks, either being viral or bacterial in immunocompetent adults. On other hand, sometimes immunocompromised, it might be difficult to diagnose. So all these things we are well aware of. And in previous video, we have discussed about pathogenesis of fever, basic treatment of fever with a paracetamol or aspirin or ibuprofen, kind of those things. So with the continuation of previous one, today is much more interesting one, which you commonly encounter in your practice as you advance in your career. Post MBBS, if you are going to do MD or MS, definitely sooner or later you will encounter a perplexing or puzzling patient whose diagnosis might be missing in our conundrum of medical literature. So especially when we are dealing with a patient whose diagnosis remains elusive in spite of our best efforts, either at the level of MBBS or at the level of post-graduation or further specialty, in that case always remember it is best to discuss the case with your knowledgeable friends or with your seniors. For example, if you are MBBS, discuss with interns, and if they still are not sure about the diagnosis, discuss with the postgraduates or even assistant professors or professors also. More often than not, your professors will be happy to discuss case with you, especially if you show interest and especially with your zeal as you discuss with your colleagues, your signs, all these things will advance. So today's topic is about fever, but a subpart of it, that is known as fever of unknown origin, also known as FUO, pyrexia of unknown origin. But current terminology is FUO, fever of unknown origin. Can you tell me previously when we defined fever, means how we define fever? Any temperature, especially oral temperature, I mean, if it is exceeding 100 degrees Fahrenheit or more than that, it is known as fever. Okay. So 99.9 means next one is decimal point is 100 only. So any body temperature 100 or more than that, it is defined as fever. Please remember this always. So basing upon this step 1 means milestone, now we are going to advance into this topic, which is quite relevant and helpful for your examination, especially during final year and also while preparing for postgraduate entrance. Previously there were 2 doctors. One is Professor Beeson and his student is Petersdorf. They published a landmark article in Medicine Journal way back in 1961. Prior to that, there was varying definitions of this confusing terminology of undiagnosed fever. Some used to call it as a latent fever, some used to call as malignant fever or benign fever, kind of those things. But they coined a term that is known as fever of unknown origin or pyrexia of unknown origin. As of now, we should call it as FUO. So the original definition is this one. Petersdorf was a resident of Professor Beeson when they were at Yale University. According to them, fever should be present for at least 3 weeks. At least 3 weeks. Remember this thing, because it is uniform across the generations and at present also it is applicable. Second one is any temperature exceeding 101 degrees Fahrenheit on 2 consecutive occasions. So single episode of fever doesn't meet the diagnostic criteria of FUO. So this criteria is still applicable. So these 2 are well and good. In those days, patients used to be admitted in hospitals. So, they presented this criteria, at least 1 week or more than that of inpatient evaluation. But nowadays, with advent of science, patient need not be admitted in hospital for fever. There are many sets of investigations that are available outside, means basic tests which we can do. So, what are those must tests that one should do if a patient is having fever of 101 degrees Fahrenheit on 2 separate occasions? First 2 criteria are satisfied. Third one is patient shouldn't have any immunocompromised state like HIV, like any other viral infections like Epstein-Barr virus, or organ transplantation, or CKD, or even primary immunodeficiency disorders or secondary immunodeficiency disorders, especially related to glucocorticoid usage. So, exclude any immunocompromised state. Okay, got the point? So, when a patient is having fever for more than 3 weeks, more than 101 degrees Fahrenheit, these are the tests we require. One is basic one, hemogram, that includes inflammatory markers. About these things we had discussed in the previous presentation, that is CRP. Second one is ESR. So, these are the markers of inflammation. Of course, previously also we had discussed, in the absence of fever also inflammatory markers will be elevated, that is known as IFO, that I will discuss in next slide. Second basic tests are kidney function test, liver function tests. Almost 100% of labs will do these things. Next one you shouldn't forget is LDH, marker of systemic inflammation, lactate dehydrogenase. You know these things. What are these two? ANA and RF. Many people write it as serum RA. We should write RF. R means rheumatoid. F means factor. So, rheumatoid factor test, and ANA, anti-nuclear antibodies. So, these two are meant for systemic autoimmune disorders like systemic lupus erythematosus, rheumatoid arthritis, but also other connective tissue diseases. Other things we are going to include are basic radiology like chest X-ray and ultrasound abdomen. We shouldn't forget radiology here. Okay? So, these are the common tests most of the labs in our country they do. But here we have to be little bit specific about these CPK and ferritin. These are also inflammatory markers. And CPK elevation is suggestive of involving creatinine phosphokinase. So, where this enzyme is localized? In our muscles. So, any elevation in CPK is suggestive of damage to muscle. So, one shouldn't forget doing this CPK and ferritin. And other sets of investigations which we ask are routine urine test like urine examination, looking for any pyuria or any hematuria, kind of those things. Usually we label it as pyuria when pulses are 5 or more than that in high power field. And remember, WBC tests are always abnormal and the presence of RBCs are always abnormal except in a menstruating woman. Got the point? Okay. So, urine culture we have discussed, complete urine examination we have discussed. So, what are those things which we often neglect? So, how to take blood culture samples? There were many schools of theory about how to collect blood culture at different times, at different sites, kind of those things. But most important is take the blood culture, at least 3 samples, either from the same site or ideally from different sites on different occasions, especially when patient is having febrile illness. That is most important. Taking blood culture is important, but how you take that is left to your clinical discretion. And last one, but very important as far as our country is concerned, is tuberculin test. It is a skin test, means on forearm we do the test, we read the test after 48 hours or sometimes more than 72 hours also, some people will take time. After giving tuberculous antigen, they develop erythema, induration, sometimes ulceration also. It is indicative of previous infection, or in those BCG vaccinated, unfortunately it will show previous exposure to Mycobacterium tuberculosis. And theoretically supposed to be not affected by BCG vaccination is IgRA. The test you often encounter those students who are leaving for developed countries like US or UK, where they mandated this test. Interferon gamma release assay, it is a blood test. So in that test we will come to know whether we have been exposed to tuberculosis or not. If it is positive, they label it as latent tuberculosis, even if you don't have any manifestations. And in developed countries, ATT is mandatory for latent tuberculosis. But unfortunately in India, latent tuberculosis is subsumed as normal. If at all, if we treat latent tuberculosis, majority of the population should be treated with ATT, because that is not possible. So here in India, we are neglecting latent tuberculosis part. Okay, that is a different subject. Let's go to next slide. In previous slide, we have touched upon one point: inflammation, inflammation, inflammation. What are those inflammatory markers? ESR. Second one is CRP. About CRP, we have discussed much in previous video. That is about fever. So I am not going to entertain much more about these things. Not going to discuss further. Third one is ferritin. Actually, in the absence of inflammation or any fever, ferritin is a very good marker for our tissue iron storage. The normal ferritin levels vary widely. So low ferritin levels are suggestive of iron deficiency even when hemoglobin is normal. On the other hand, if ferritin levels are high, either it can be iron redundancy, means fully iron replete, or in the setting of fever or inflammation, it is a marker of inflammation. So please remember these three. There are many other inflammatory markers which we are not going to discuss. It will take lot of time. We limit our subject to FUO, fever of unknown origin. ESR, CRP and ferritin. If you remember these three, it is more than sufficient either for second year or final year students. Okay. Now talk about this phrase, inflammation of unknown origin. This is FUO. This is IUO. IUO is essentially same as fever of unknown origin, except that the person might not have fever or even undocumented fever. So in a person, if you are seeing these markers are very high but no fever, still you have to do those previous, these tests that I mentioned. These investigations one has to do. This is mandatory. Hemogram, CRP, chest X-ray, tuberculosis test, culture, all these things. Fine. Now we will come to etiopathogenesis. Etiology means causes. If we go on discussing the causes of this fever, I think we will end up speaking throughout the lifetime, because any disease can cause fever of unknown origin. Please remember, any agent including our modern drugs, they can cause fever. That means most of the times the fever happens because of the atypical presentation of usual pathogens or usual drugs we prescribe. For example, a patient might be having fever with a simple, you can say viral fever, most of the patients for 1 week at the maximum. Okay, having cold and cough, kind of those things, then you will give some antihistamines. If fever is there, you will give paracetamol, but you are not going to subject to those all those investigations like hemogram, CRP, cultures, what we have seen in previous slide. On other hand, some patients will have persistent fever for next 1 to 2 weeks. So majority of the patients means almost 80% of the patients, their fever subsides by 1 week. Some patients might have got lingering symptoms, means still they feel weak, fever will come and go, they want to lie down, they don't want to go to work, they love to watch Instagrams only. So that will last in at least around 10% of these things. So total 90%. In remaining 10%, either it will remit or it may progress to fever of unknown origin. So here please remember, the pathogenetic organism is same, either it is virus or bacteria. Why it happens? Might be because of the genetic factors of the patient, might be because of the change in the virulence of virus or bacteria, or associated conditions which the patient might have got, like age, drugs, which may confound the clinical picture. So is it clear? That is fever, when to we have to evaluate, especially for fever of unknown origin. I reiterate again that most of these fevers are due to our common pathogens or common agents, that includes drugs also. So infections, all kinds of bacteria and viruses, especially related to our endemic areas. What are they that are relevant to India? Dengue fever, enteric fever, that is typhoid fever, tuberculosis. Look at these things. And another one is even leptospira also. Coming to other things which are non-infectious ones, either inflammatory or autoimmunity, because these are related to immunology. In the chapter of fever, I had discussed about one inflammation. What is that? Adult Still's disease, hyper IgD syndrome, kind of those things. What that thing you often see in your practice? This question is for those who are doing internship. GOUT, gout. Especially with the modern lifestyle in males who are on high purine diets like non-vegetarian stuff, they may have got low-grade fever in the absence of gouty attacks. Usually, gout manifests as swelling of the first metatarsophalangeal joint, or even sometimes involving the ankle joint or knee joints. So, any fever, if it is there, when you vigorously rule out infections, suspect gout or other autoinflammatory syndromes. Second one is autoimmunity. In adults especially, it is polymyalgia rheumatica, systemic lupus erythematosus, and even rheumatoid arthritis also one has to suspect. Got the point? SLE, polymyalgia rheumatica or rheumatoid arthritis. Fine. Infections, non-infectious etiologies. What are other non-infectious etiologies? Neoplasms. One is benign, another one is malignant. You might be surprised why even benign tumors may cause fever. It happens because of their cytokine profile. It can happen because sometimes they may undergo necrosis. necrosis, cytokines. So whenever tumor is devoid of its blood supply, it get necrosed. So it will release its contents, which may elicit the inflammation and fever also. So look for benign tumors, especially hematomas, kind of those things, hemangiomas also. Concerning to malignancy, they can be either solid tumors or related to our myeloid system, that is lymphoma, leukemias, kind of those things. So any patient after age of 50 years, if fever is there, in spite of extensive evaluation, look for malignancies, especially in smokers, like lung cancer, or in women it is breast cancer, sometimes renal cancer also, that is kidney cancer, renal cancer. So any patient coming with a fever for more than 3 weeks, no infections, suspect cancers unless proved otherwise. Even pancreatic cancer also can lead, but it will become quite vast. That's why I am not discussing all these things. Otherwise, you will run away from this class. So coming to next point, that is disorders of thermoregulation. In previous presentation about fever, we had discussed extensively about thermoregulation, that is how fever happens because of toxins, or because that might be either endotoxins or exotoxins. They release the cytokines. Because of them, what I have told, prostaglandin E2 will come. This prostaglandin E2 will increase the cyclic AMP levels. The cyclic AMP increases thermostat point of hypothalamus. Got the point? Hypothalamus means the structure within the brain which regulates our body temperature. So any process affecting this hypothalamus can cause the increase in the body temperature, like stroke or any tumor there. So these things increase the core body temperature, including our common heat stroke in summer months. Okay, clear so far? Infections, non-infectious etiologies, inflammatory, autoimmunity, neoplasms, and thermoregulation. Finally, other causes which are important, one should neglect. Remember, this is not exhaustive presentation. I am not going to tell each and every point of this etiology of fever, otherwise it will take days together. So among these miscellaneous, you have to suspect the peripheral causes like hyperthyroidism, or you can call thyrotoxicosis, where there is excessive release of thyroid hormones from the thyroid gland, where thyroid will be overactive. Second one is pheochromocytoma, means excessive release of catecholamines from the adrenal tumor. Adrenal tumor. Let's erase this for a while. So one is thyrotoxicosis, increased release of thyroid hormones. They can lead to fever. Patients will be going around doctors and they will be evaluating for all these etiologies, nothing found out. Finally, they will come to endocrinologist. Second one is pheochromocytoma. Chromocytoma, where there is release of excessive sympathetic amines. So what are they? Adrenaline, nowadays we call it as epinephrine and norepinephrine. So epinephrine, norepinephrine can lead to elevation of body temperature, persistent elevation. So these things we have to exclude. Other rare diseases like IgG4, this is recently described, means for almost 8 to 10 years. It is also a part of autoimmunity. Here it can affect any gland in the body. It can cause diabetes, various kinds of manifestation like pancreatitis, kind of those things. So, IgG4 disease. Okay. I think this is more than sufficient for an MBBS final year student or those who are appearing for NEET PC. So, dear students, so far we have evaluated common causes of FUO, that is fever of unknown origin, and your very thorough history and physical examination, still cause was not found out. Then what will you suspect? Then you will resort to another sort of investigations, but that is not the case. So, because as a teenagers or in youth, you might not be knowing entire world. Just for anything else in the world, there are two sides of a coin. There are shades of gray also. So, in those gray zones, as you get experience in your life, you will come to realize not all persons are reliable. By this time already you might have got some sense of which I have told, either in your personal life or your professional life. Everyone cannot be trusted. Though the first dictum in medical science is that you should trust whatever patients say, but sometimes you can say it is our gut feeling or because of experience, you may find mismatch between what patient is telling and what actually the condition is. Previously it was known as malingering. As far as FUO is concerned, there are two terms for that. What are they? Quite interesting. Listen carefully. One is fraudulent fever. Second one is factitious fever. So, fraudulent fever. Here it itself shows fraud means patient trying to defraud you. So, why is he doing like that? Might be out of his some compulsions, financial obligations. He might have run away from his financiers, his lenders. Sometimes he might have cheated upon his better half or lesser half, whatever you call, or just because of some psychiatric components, they might be doing these things because of frustration. So, what is that fraud patient is doing? One is manipulation of thermometer. Thermometer manipulation. For example, many of the workers, they evade from the duty, citing fever as one of the things they are suffering from. Sir, my son has got fever, I have got fever, that's why I am not able to come to work. Please grant me leave for 10 days or 2 weeks. I want to go for outing with my family. That is okay, subconscious wish. Here, they will manipulate the thermometer. What are those sites where we usually measure temperature? Oral, axillary, kind of those things. Common things. Rarely tympanic membrane or forehead. Here, instead of measuring his actual body temperature, he or she will insert the thermometer into a warm water or hot water. So, more than 40 degrees centigrade, then they document fever and they apply for leave. If the manager is an idiot, then he will immediately grant the leave. So, few of the patients, not everyone, they will come for this. They pretend sickness. So, they apply for sick leave. So, instead of measuring actual temperature, they manipulate the thermometer like this, and this is nothing but fraud activity. This is known as fraudulent fever. This also you have to keep in mind. Okay? There is subtle difference between fraud and factitious. This is also actually fraud only. Factitious means pretending, false. There is no fever, but patient shows that he or she has got fever to gain sympathy or some emotional advantage. Whenever there is a fight between wife and husband, wife might be resorting to these things. Of course, husbands are also no exception. Here the patient injects himself or herself with tap water. They will take a syringe, buy from a medical shop or pharmacy. Instead of usual injection, they take from tap water, they pull it and inject here itself. So, any tap water or anything like that, even common notorious drugs also, like usual talcum powder diluted water or even illicit substance like ganja. So, they can lead to elevation of body temperature. Here the patient develops a fever because of these things. This is nothing but self-harm. Injecting themselves with tap water or some other pyrogens, or even with ganja kind of, and developing fever and applying for sick leave. This is nothing but factitious fever. So, in fraudulent fever, the patient doesn't have fever. He will just show the record. Whereas in factitious fever, actually patient will develop fever, but this is not because of infections or any other things were discussed. He or she is harming themselves. So, how to catch these patients? Okay, it is like a Sherlock Holmes. One is because usually we take temperature from the oral cavity. If the patient dips that thermometer in hot water, it will show 40 or 41 or much more than that. So, those sites which are inaccessible to the patient, what are they? Rectal temperature, or another thing, esophageal. Any discrepancy, it is suggestive of patient is manipulating us. Got the point? Another clue to fraudulent fever is measure their pulse rate. Previously we had discussed, with the fever temperature increases with every 1 degree Fahrenheit. That is also known as a Bouwmeester formula. At least 4 to 5 beats per minute, that is increased pulse rate, 1 degree Fahrenheit, or for 1 degree centigrade you can say approximately 10 beats per minute increment will be there. But here in this thing there won't be increase in any pulse rate because patient doesn't actually has got fever. So, in this way you can catch that person who pretends that they are having fever. But these people are quite notorious, factitious, because they know how to dupe. Even experienced doctors, nurses, sometimes they resort to these things, especially those who got access to drugs. So, especially in medical professions like nurses or paramedical staff or even doctors, if they pretend a fever and if you get doubt and if they got temperature, suspect this factitious fever. Okay. Third one is drug fever. Please remember, any drug on earth, means any medicine can cause fever. Whatever you take, whether it is penicillin that we are not often using much, or all other drugs which are nowadays we are using like cephalosporins, or those neurology drugs especially for seizures like anti-epileptics, or those agents like B complex, iron, sometimes they can cause fever. So, any patient is having fever, still undiagnosed, suspect drug fever, drug fever, drug fever. So, by this time hope you are clear. First you are going to do basic physical examination, of course thorough history followed by thorough labs, and exclude these causes: factitious fever, fraudulent fever and drug fever. Got the point? We will proceed to next slide. So, dear students, by this time hope you are all clear about definition of fever of unknown origin. Simple evaluation means basic steps what we have to do and which things we have to suspect first. Okay? 101 degrees Fahrenheit for more than 3 weeks on at least 2 different occasions, basic sets and documentation, that is important. Okay? So, with this we have developed solid concept, that is basic foundation, and you have done very thorough physical examination and comprehensive history taking. Previously also I have told many times, history and physical examination form stepping stones for your success of your career. talk to the patient, ask the patient, bother him. Sometimes, especially in such difficult scenarios, you are going to realize the importance of history, though it appears quite simple. Sometimes it appears nonsensical, but over a period of time, as you come to know about that patient, his social history, his family history, his habits, and his travel history, whatever it is there, some pointer that is known as PDCs. What is P? Potential means probable, mostly probable, most probable, potential. D, diagnostic. C, clue. So, by spending as much time as possible in productive way with the patient, history and physical examination, in 90% of such difficult cases, you will elicit these PDCs, potential diagnostic clues, which will impress your professor, and you may be rewarded with a gold medal in final examination. Okay? So, basic test already we had discussed, that I am not going to discuss again and again. These two things just now we have discussed. Manipulation by patient or patient attenders also sometimes, and drug fever also we have discussed. So, whenever you suspect drug fever, means any medicine causing the fever, stop those medicines if they are not required, like including even B complex also, even NSAIDs also, like crocin, ibuprofen, whatever they are there, if they are not required. And watch for next 3 days, means for next 72 hours. Okay? For next 72 hours, if the fever subsides, the diagnosis is drug fever. So, you can stop investigating all these things and you can send the patient back to his home, and they will be more than happy and they reward you. Sometimes, not everyone is alike. Mangoes, kind of those things, sweets, because they have moved around many doctors, nobody has diagnosed except you as a second year student, as final year student, you have found out that some medicine is causing the fever. Stop even iron tablets also, because in most of the times they are not must, at least in acute settings. So, if fever remits within next 72 hours, this is a drug fever. They need not have eosinophilia, because many of us think that, traditional thinking that drugs elicit fever by inducing eosinophilia, but that is not the case. There are many mechanisms where usual medicines elicit fever in the absence of increase in Ig levels or eosinophils. Okay? So, step 1 is over. This is step 1. Fine. This is the second thing we are going to enter. This is analogous to, you know, Mahabharata, where son of Arjuna, who is he? Abhimanyu. He enters a battlefield in Kurukshetra, a scheme devised on that day, actually to kill his father Arjuna, but Krishna has diverted that thing. That is okay, different topic. That is known as Chakravyuha. Chakravyuha. So, here you are entering Chakravyuha, means it is easy to enter but difficult to get out. So, here you have to take help of your friends, your colleagues, your professors, etc. But believe in yourself. I am stressing again and again, if required, take again history, again do physical examination. Okay? Don't go on repeating the labs. So, sometimes there will be clues, like any mass or any occult pus accumulation, that is known as abscess, that you can evaluate. Okay? Here it stops. That means you are safe to come out of this war. But on other hand, like Abhimanyu, if you are not finding anything, just going on fighting with your enemies with no clues who is the enemy, who is going to kill him. So these ammunitions are helpful, like cryoglobulins and fundus examination, especially by taking the help of ophthalmologist if you are not expert in examining retina. Okay. So now we are in the war zone of FUO. Here what are our in our armatorium? Cryoglobulins and fundus examination. So what is the role of cryoglobulin? You may ask. Always take care that the test tube which you are sending for the laboratory should be at 37 degrees centigrade. Otherwise test will give false negative value. So always send the blood sample in the warm, means at 37 degrees in that bathtub. Otherwise there is no fun of doing this test. Okay, which conditions cryoglobulin do suspect? Cryo means lower temperature. Cryo, temperature sensitive. So which conditions you have to suspect? There are many conditions which might be revealed in this one, depending upon their monoclonal or polyclonal nature. Monoclonal means belong to single clone of cells. Second one is polyclonal. So if you see monoclonal cryoglobulins, you have to suspect cancers. So what are they? Again, lymphomas or multiple myelomas or Waldenstrom macroglobulinema, kind of those things. On other hand, if you see polyclonal or mixed pattern, you have to suspect autoimmune diseases which we have discussed, like SLE, dermatomyositis, even polymyalgia rheumatica, kind of those things, rheumatoid arthritis, which can cause fever. So if you are doing this cryoglobulin, look for their pattern. If they are revealing, well and good. If not so, what we have to do? Because in that Chakravyuha of Mahabharata, Abhimanyu has penetrated almost 16 to 20 layers, I think, as far as I know, with my limited knowledge. So we have penetrated 1, 2, 3, 4, 5, 6 layers. 6 batches of enemies we have evaluated. Here still we are there. Patient is getting frustrated, patient family is getting frustrated. They will say, sir, you are doing so many tests, but it is not clear. What is happening to the patient? Why you are not able to diagnose in this modern era? But please tell him that for everything on earth there is no answer, including any in their personal life. For example, if they have met an accident while coming to hospital, what might be the cause? It is a random event, chance event, which is not predictable. So in workup also, sometimes predictability, or many times we can say, doesn't matter. It is all depends upon our thorough evaluation. Sometimes time is going to reveal, isn't it? For example, just like relation between wife and husband, where their intimacy or proximity will be revealed over a period of time, whether they are cheating on each other or not. Here also time matters. Sometimes disease may begin to show its manifestations over this period of time, either 1 week, 2 weeks, 3 weeks, or even months also. So ask them to be patient. That's why we call our customers as patients, means they should have patience. Without patience, either patient or doctor, they will be at disadvantage. Got the point? So when they are discussing with you, you shouldn't get frustrated. We have done workup so far here, but still no reason we couldn't find out. Sometimes it will happen. If so far nothing is there, might not be, it is sinister, means life threatening. Life threatening means cancers, kind of those things, which can lead to heart attack or deaths. Because in idiopathic variety of, I am going to tell this important statement, FUO. In idiopathic means after thorough evaluation of all these things, if no cause is found out, 90% of patients are going to recover sooner or later. Okay? assure them. Then what that next thing is left? FDG PET, fluorodeoxyglucose PET, positron emission tomography combined with CT scan. This is the one of advantage of modern imaging techniques. 30 years ago, we didn't have FDG PET. Till here we used to evaluate. After that, samarpiti kiya, got go. Or we used to start anti-tuberculosis treatment. But with advent of this imaging technologies, where there is a fusion of physiological and anatomical. So FDG PET is physiological. It depends upon the glycolysis of or glycolytic pathway, cells taking up the fluorodeoxyglucose, which can be quantified. So you can approximately find out a site where this is increased. When you are fusing this physiological one with anatomical staging like CT scan. CT scan is nothing but computerized tomography. So when you fuse these images, you can essentially localize where this problem is. So you can pinpoint. So you may hit the bullseye. Bullseye means you may find out the etiopathogenesis of the fever. Okay? But remember, there are also exceptions to this FDG PET. FDG PET is not 100% sensitive, it is not 100% specific. So we are going to discuss a little bit about FDG PET, but not exhaustive one. Don't fear, because FDG PET is one of the most important investigations as far as FUO is concerned. Because once you get FDG PET, most of times no need to repeat second scan. Please remember, don't repeat investigations, don't repeat FDG PET or any radiology unless otherwise you are getting some clue in your history and physical examination. Okay? So FDG PET will detect any site of inflammation. Either inflammation can be innocuous or it can be treacherous also, malignant also. So it won't distinguish between infections and malignancy. Okay? And also there are many tissues in our body which take up this FDG because of their metabolic pathways. What are they? Our constantly functioning brain, heart, kidneys, or because of urine accumulation, bladder. So in those sites, if you see increased FDG uptake, it is normal. The problem with FDG PET investigation is that there is one entity known as giant cell arteritis, where there is inflammation of the extracranial vessels which are adjacent to the brain. Brain is there, adjacent vessels are actually inflamed, problem is there. In such settings, if you do this FDG PET scan, this physiological uptake may overwhelm this pathological, means it will obscure this pathology. So in such settings, FDG PET may not reliably detect the disease. Okay? So where anatomical proximity is there. What is the second one? When there is no active inflammation. When there is no active inflammation, means for a period of time the disease has burnt out, it has taken rest, or patient was given steroids or some NSAIDs by doctor or quack. So automatically when a patient is taking steroids, FDG PET is not recommended. So after stopping these steroids for at least 5 or 4 to 5, you can say biological half-lives, you can go ahead with this FDG PET CT, depending upon the steroid, whether it is a prednisolone or methylprednisolone or dexamethasone, whatever it is there. Okay? Third one, where FDG PET spuriously may not detect. What are those conditions? Low metabolic activity, tumors. Many of the solid tumors may not detect, especially if they have got low glycolytic pathways. Okay? So in such settings, we have to be judicious when to order FDG PET. So what is the ideal time? Please guess. Especially when there is evidence of active inflammation, means either presence of fever or immune markers like our ESR, CRP. During those active inflammation phases, if you do this FDG PET scan, they will pick up. Another most important thing which you shouldn't forget is diabetes, because already in diabetes sugar levels are high. Diabetes, these increased glucose levels may decrease the sensitivity of FDG PET. So, if the patient is having diabetes and is subjected to FDG PET, control his glucose levels well, means less than 120, then only order this scan, otherwise you are going to miss the diagnosis. Got the point? Say in grandmodern days, means around 20 or 30 years back, when the FDG PET was not available, we used to do few tests. Just for historical importance I am telling, what are they? Gallium based scintigraphy, it is an element which accumulates at the site of inflammation. But the problem is sensitivity is lower, means it is not as good as FDG PET to detect these pathologies. So, it is for inflammation irrespective of whether it is infectious or non-infectious. Second one was technetium based leukocyte which were tagged with the technetium scintigraphy. So, whenever there is infiltration of leukocytes, these tagged WBC do accumulate, and they were suggestive of any loculated means confined infection, which may not be detected by usual ultrasound or X-ray kind of those things. So, in latent purulent infectious etiologies, we used to do these things, but with FDG PET they have fallen out of favor. Nowadays these are not used much except in those centers where FDG PET is not available, then you can go ahead with these investigations. Recently there was comparison of whole body MRI with FDG PET, because FDG PET is okay and there are limitations that we have discussed, and there are limitations for CT scan also, because some patients may fear repeated CT exposures. In such settings, if the patient is otherwise eligible, you can subject to whole body MRI. It is very costly investigation, but fortunately it has found out to be equally as good as our FDG PET. So, it is an evolving technology, please keep in mind, and if you tell this your professor that whole body MRI is the recent investigation which is showing as good sensitivity as FDG PET, you may be rewarded with some medal. Okay, let us go back to our approach. Now we have reached this conundrum. Here we are fighting in this never ending battle. We have reached almost step 2, step 3 kind of those things. Step 2 is over. So, step 2 is up to FDG PET. Still on FDG PET, we are not finding anything. What we have to do? There are only two options left. One is again go back to the patient, go back to his family, again take history and physical examination. Never do other tests. Don't repeat any blood test or or any microbiological serological tests which in previous days we used to do, or never repeat FDG PET if it is done properly. Okay? So, go back to the patient, take history and physical examination, thoroughly ask him, again come back. Still nothing it is there. Now, we have to serially follow up the patient. At this time, means by this time already time might have elapsed by almost weeks, means third week, fourth week, 1 month, patient will get frustrated. For how long I have to come? You are not doing anything. You are not able to diagnose. Shall I go to any other doctor? Okay. Sometimes taking second opinion is very good option, especially in specialized centers. For example, in our India, what are those specialized centers, especially related to our central government related, either AIMS or PJ Chandigarh or like JIPMER. There they can approach general medicine department or infectious disease specialist. So in such settings, taking second opinion might help. So when FDG PET is not revealing, what we have to do? This is the subject what we are discussing. Taking second opinion from an expert center or from an infectious disease specialist, or sometimes utilizing the AI, means artificial intelligence driven algorithms, not ChatGPT. There are specifically medical field related AI algorithms which you can use so that sometimes we may find out that these clues we are missing. So we have to pursue in those subtle directions. But never supplant your natural intelligence with artificial intelligence. Your brain comes first. AI is your assistant. It is not your master. Please remember. Don't open ChatGPT or something else and start reading. Because most important thing is you have to utilize your brain. Even this FDG PET shows the structure that avidly concentrated is our brain. No AI can match our natural intelligence. Okay? Your purpose is to utilize artificial intelligence as an assistant in those cases which you may require somewhat obscure, means hidden clues. Okay? That is the one thing. Taking second opinion and utilization of AI. If the patient is stable at that time, means only low grade fever is there, patient is not deteriorating, he is quite conscious, coherent, accepting food, vitals are stable, then you can have trial of either NSAIDs or even paracetamol, or just observe if the patient or his family agrees. So intermittent usage of NSAIDs might be helpful. So in meantime, that disease which is lurking in the dungeons may come out like a demon, if at all it is there. Most of the times it is benign. But see here, if the patient is deteriorating, patient have already paid a bill of 10 lakhs at a corporate hospital and diagnosis has not arrived. Patient and their attendants are creating a ruckus or chaos. We have spent so much, patient has not improved, is deteriorating, you corporate people are like this, you have taken 10 to 20 lakhs but no diagnosis. It has recently happened in a nearby corporate hospital. Then only option left is therapeutic trial. Therapeutic trial of what? Depending upon the context, either you can give steroids or you can give anti-tuberculous drugs or even antifungals also, because otherwise patient may not survive. Patient is deteriorating, he may land up in ICU, coma. So you can utilize these drugs. If the patient improves well and good, okay. If not, nothing can be done, because in around 5% of cases, some say up to even 30%, in spite of extensive investigations, no cause would be found, because science after all is 50-year-old. From 1950s, we have seen origins of our science. From the antibiotic era of penicillin, then we have gradually progressed. Now we are in 2026. Now we are in areas of high dose chemotherapies related to cancer and antibiotics. But human race is for almost 5 lakh years. So tell them that science is still yet to evolve and there are many diseases that are going to uncover. And in last 10 years itself, so many new diseases have been found out, including our popular COVID-19. Because prior to 2020, nobody, including 99% of doctors, know about COVID. We might have fleetingly come across that term known as coronavirus, but we used to neglect. So in meantime, if the patient is stable, just observe and new disease may come up. Or a already common disease with the atypical manifestations might be there. So, these are the options that have been left. Treat with NSAIDs if the patient is stable. If the patient is becoming bad, unstable, give a dose of either antituberculous therapies or antifungals or glucocorticoids. Okay, got the point? This is the broad approach for a patient who has got fever for more than 3 weeks, which has been documented repeatedly, means more than 2 occasions, and for at least 3 weeks. So, this completes the approach to the fever of unknown origin. Dear students, so far hope it is clear. If you have got any doubts, please ask me or drop comments so that I am happy to answer you. Because learning is always, earlier I have told many times, it is a two-way street. As you are learning from me, I am learning from you. So, what is required, that is most important for the common benefit, that is patient recovery. That is why sometimes taking second opinion is important, as discussed in the previous slide. We shouldn't go to our egos, means inflated ego, that we shouldn't think that I alone can diagnose this case. When you got doubt not only about FUO, any case, discuss with your colleagues or over internet also in academia. Okay? So, coming to final section of this topic, that is treatment. Already you might have got doubt. The patient has got fever for a very long duration. He might have got disillusioned with allopathy, that means modern medicine. He might have gone to Ayurvedic or homeopathy, or you might have gone to Shimoga, where natural therapy is given. Do you think they are going to give some extra treatment that is going to be especially helpful? No, these are desperate measures. When modern science cannot find out or cannot treat diseases, patients have got frustrations or unrealistic expectations, which sometimes do harm, means abandoning the treatment completely. So, in such settings, you shouldn't be judgmental. Always you have to be empathetic. See, it is not synonymous with sympathy. Empathy means understanding others' concerns. Sympathy means showing your concern for others. Okay? This empathy is important. Empathy means where you are analyzing the patient situation, where it is going wrong, so you can assist them in their prognosis or progress. Okay? If the patient says or his family says, we are going to take herbal medicines, okay, you can take it, as long as they are not going to interfere with our diagnostic workup or your overall health being. The problem is these drugs, especially related to alternative medications, many of them are contaminated with steroids, some natural forms or some artificial. So, if they are taking those alternative medicines, either you can send them for chemical analysis, but unfortunately in India it is not possible in most of the places, because the so-called Ayurvedic or homeopathy, they may be contaminated with steroids. So, you know, steroid can suppress any fever, right from viral fever like our COVID. We used to give glucocorticoids for COVID, and also for malaria, typhoid, everything our quacks used to give as a treatment for fever, and patients would be very happy. I have wasted lakhs of money around these corporate hospitals. By simply visiting an RMP, my fever got subsided. Why it is happening? This is the gap between your way of approach and patient expectations. Patient expectation is cure or at least control of his disease. But what we are here doing is, we are doing extensive evaluation. But where is the treatment? So, in this loop, in this Abhimanyu Chakravyuha, unlike Abhimanyu, who couldn't come out of this war, here we had to come out. We had to wage a war. We have to find out an exit where patient will be benefited and we will be happy to see patient back to his normal condition. So, while taking history and physical examination, always consider possibility of treatment in the midway. Otherwise, patient will be lost to some quack who is sitting in some hotels and advertising over internet or newspapers also, telling that they will cure anything on the earth. Because patients definitely expect miracles at that time when nothing is found out during our evaluation. So, what are those drugs which we can give? depending upon the status. If the patient has got neutropenia, just a simple question, what is neutropenia? Neutropenia term itself shows diminished neutrophils. The currently accepted cutoff for neutropenia is less than 1500 polymorphonuclear leukocytes per microliter, less than 1500. Okay, there are many degrees, mild, moderate, severe or agranulocytosis, that is we are not going to discuss. For this moment, please remember this figure, less than 1500. Whenever your assistant professors or professor ask this question, what is meant by neutropenia, if you tell this, they will be more than happy. Okay. So in the setting of neutropenia, you can give antibiotics, provisional antibiotics. Depending upon the clinical context, the coverage can be given for gram positive or gram negative bacteria or even few antivirals also. Okay. But one of the notorious conditions in our country is miliary tuberculosis. Patient has got high grade fever, chest X-ray normal, everything is normal. These tests are also negative. But the patient is having high grade fever, not remitting except with some paracetamol for some time. But it will be relieved by glucocorticoids. So in such settings, if at all these tests are positive, either TST or interferon gamma release assay, if they are positive, you can give ATT. So after empirical trial of ATT, that is for at least 3 to 4 weeks, if fever comes down, you can continue treatment for full course. On the other hand, if fever doesn't come down even after 3 to 4 weeks, then you can stop this treatment. Fine. There is one entity known as Still's disease, adult onset, involving joints and high grade fever. If the patient is responding to NSAIDs like ibuprofen, naproxen or even paracetamol, then you have to suspect Still's disease. So in such settings, you can give NSAIDs in addition to gastroprophylaxis with the proton pump inhibitors, kind of those things. Okay. There are few periodic syndromes. Fever comes and goes for once in 3 weeks or every 3 days, sometimes with mucocutaneous ulcerations over lips or genitals, that is known as Behçet syndrome. If you give colchicine, colchicine in a previous video we had discussed, it is a microtubule inhibitor. Okay. So when it is given, inflammation is subsided, it comes down and it will give dramatic relief. The dose actually is 1 to 2 milligram per day in divided doses, TID kind of those things, 1 to 2 milligram per day. So if the fever responds to colchicine, suspect these conditions. So far we have got antibiotics or antivirals, anti-TB drugs, NSAIDs, okay, clear. And another one is colchicine. Another important condition that often missed is polymyalgia rheumatica. Poly means all over, rheumatica, body pains. Patient will have fever, lot of stiffness in the shoulders, thighs, all these things, and sometimes fever may be the predominating feature. The symptoms of myalgia may be mild. ESR, CRP will be elevated, especially in elders, means more than 60 years of age. If a person is having undiagnosed fever with the muscle pains, then you have to suspect polymyalgia rheumatica, and treatment of choice is glucocorticoids, prednisolone or methylprednisolone. But again I am cautioning you, here it is a catch. Smoldering means evolving like a lava before volcano burst. There might be lymphoma, means proliferation of lymphoid cells. So, at later stage patient might have got malignant lymphoma. So, a word of caution, keep an watch always on this lymphoma before resorting to glucocorticoids. This is nothing but clinical intuition, means using your brain. Otherwise, there is no difference between us and a quack who simply gives steroid for each and every fever. Okay? Don't give steroids to each and every case of fever. There are so many options here. Coming to the last part of this treatment, these are rare diseases that already we had discussed in previous video about fever. Autoinflammatory diseases. What are they? So many things were discussed. Pyrin related, TNF receptor, TRAPS syndrome. Here also glucocorticoids are effective, but as science has advanced, in these diseases, if you suspect, the final common pathway is interleukin 1 or its stimulatory effect on the interleukin 6. There are two isoforms of interleukin 1, interleukin 1 alpha and interleukin beta, and there is one monoclonal antibody which inhibits both, that is known as anakinra. When you suspect autoinflammatory diseases, rather than giving glucocorticoids, please give this anakinra. Okay? So, here our clinical judgment plays a role. Hope you got the point. So, in spite of all these things, if the patient is doing fine, eating properly, and there are no bowel disturbances, they are going to survive for at least next 5 to 10 years. They may die of other comorbidities, but risk of mortality is very low, less than 5%. If at all a patient dies, during workup itself, first 2 to 3 weeks they will die. If a patient is alive after 3 weeks of extensive investigations, especially I have told you, what is that investigation of choice? FDG, PET CT, fusion imaging. If it is normal, then risk of mortality is very low, because chance of malignancy is quite low in such settings, though it can't be ruled out. So, one of the reassuring markers for longevity is normal FDG PET. I hope with this we have reached the end of this session. Just to recapitulate, FUO, fever of unknown origin. Summarizing, first point what we have discussed, fever of at least 101 degrees Fahrenheit or more than that for at least 3 weeks duration. That is the definition. More than 101 degrees Fahrenheit for more than 3 weeks on 2 or more occasions. No immunocompromised state. No immunocompromised state, and basic labs. By this time, 70 to 80% of cases, they will turn out to be atypical presentation of, means different presentation of common diseases. On other hand, if still unrevealing, we are doing FDG PET CT. If it is normal, most of times patient will survive. If it is abnormal, then we are going to further evaluate. Simple, isn't it? So, that's the discussion about FUO. Dear students, if you find this topic interesting and thought provoking, please post comments or ask me any questions. I am happy to discuss. Any other things, please let me know. Thank you.